Alrighty, and I want to introduce Eric for those who don't know him. And we're going to be talking about the biokinesiology of tissue repair. So Eric, I'll turn it over to you.
All right, thank you so much. Happy to be back. We did our first lunch and learn with you guys in February, I think it was, Starla. We did a kind of a fun topic. I have to apologize in advance, tissue repair and the science and didactic component of this topic is not as fun as overhead throwing and listening to Mike Sosha and of course the great Kyle Yamashiro partake in that lunch and learn. So this one's as important as it is, maybe not as exciting, but something for sure that we think is important for what we do as physical therapists, athletic trainers, and in healthcare. I was telling Starla that we and Kyle, we did this lecture originally. It spun out of a need to teach younger therapists and the therapists over there with the Olympic team in Beijing, China, about tissue repair, because it really is the crux of successfully getting great outcomes. So it was originally a 5 or 6 day, full day course with labs, and that we shrunk down into a 45-minute lunch and learn so we can go through topics. Hopefully it's not too vague. You can only fit so much into 45 minutes. Topics quickly that we're going to look through are the following. So what specifically are we treating? The one thing we see with therapists is, they get a diagnosis of shoulder pain and we'll say, okay, what are we treating? And a therapist or the aide or the athletic trainers, they'll say, oh, we're treating shoulder pain. Well, we should be in the mindset of what specifically are we treating? Is it bursa? Is it a nerve referral? Is it the tendon? Because all those tissues heal differently. And if we don't know what we're doing as far as specific tissue differential diagnosis, how are we going to get that tissue to heal unless it just does so on its own? We'll talk about the stages of tissue healing. And this will basically set up what we're going to talk next month, which is a lunch and learn on stem cell and PRP, platelet-rich plasma, and the use of biologics. And the protocols and the approach for that are pretty much predicated on how tissues heal, what stage they're at, and when do we implement what intervention. Today we'll go through just briefly cartilage, ligament, muscle, tendon, bone. Actually, I left bone out because plug in nerve, but bone tissue a lot of times is dictated upon when they can weight bear, and dictated a lot of times by the referring physician with fractures and stress reactions and that kind of stuff. So, but we can talk about that next month. Why are we choosing the intervention? Why are we doing modalities? Why are we doing eccentrics? Why are we doing plyometrics? When should we implement these different tools that we have in our toolbox? That's important. And we'll talk a little bit about that and the concept of optimal loading and tissue and helping and facilitating that tissue with different types of loading. Again, this is a precursor for our upcoming orthobiologics lunch and learn next month. We'll kind of go through some protocols that we've written up. One of the docs that was with the Curl and Joe group and I have written one chapter, now soon to be 3 chapters. And so we'll kind of share some of the things that we have seen empirically and in the clinic, and some of which was published by other docs around the world that are pretty much authorities on the use of orthobiologics. And if anything, we'll try and today give a tissue specific framework or train of thought for how we're looking at differential diagnosing and treating some of the orthopedic conditions we're seeing. So like we talked about right off the bat, we want our therapists and clinicians to think, what exactly is the culprit? Why is somebody specifically here? What tissue is causing their pain? Typically, we're seeing really one of 5 or 6 different tissues. Maybe it's a combination of both, but someone's either got a cartilage, labrum, meniscus, annulus type of tissue impairment. They're here potentially for a ligament sprain or tear. They're here from a muscle tendon deficit. They have a bone fracture. They have some kind of nerve origin or some kind of bursitis. Most of the time, it's one of those 5 or 6 things that we're treating, and that's what we should be teasing out on the evals with our special tests. How do we stress test each of these? How do each of these tissues heal, and what forces or loads are needed for that tissue to further heal is what we'll briefly look at today. Sometimes all those tissues might be normal. There's no tendinitis, there's no tendinosis, there's no ligament issue, there's no nerve issue. All the tissue might be physiologically normal. Maybe it's a mechanical issue that we have to look at, which is always, in the options of what's causing someone's problem. Maybe there's a leg length issue. They have some kind of lower chain, ankle foot, postural, hip angulation, strength impairment, what have you, that's altering the proximal mechanics, or some kind of scap dyskinesia or sixth scapula or something where the tissues are anatomically normal, but there's a mechanical deficit there. One of the things we talk about with students and younger therapists, younger meaning, first year to 3, 4, 5 years out of schools, let's make it even easier when we're looking at differential diagnosis. Let's tease out what exactly is causing this patient's shoulder pain. Once we can tease out, is it supraspinatus? Is it a bursa issue? Is it a glenohumeral labral problem? Well, we know what tissue it is now. We should know how labrum tissue heals versus tendon versus ligament. Impart that load, impart that treatment that's needed for that tissue to heal. Everything should fall into place. I apologize, this should be number 2 by mobility category. So 1, let's figure out and tease out what this specific tissue is and impart the load that's needed for that tissue to heal. And 2, does that person need stretching or do they need stability? Do they need to be mobilized or do they need to be stabilized? And so that shoulder patient that we think has a supraspinatus problem, that's really from a secondary impingement or a hypermobile shoulder, is probably going to get a little worse if we start stretching and mobilizing. And so, once we have an idea of does this person have what tissue is causing is the culprit, let's categorize them into, do they need something with stability, tape, neuromuscular re-ed, rhythmic stabe, strengthening, or do we need to put them in a mobilization category with our joint mobs, our high velocities, and stretching? And if we can get basically these 2, kind of strategies in place, we should get a pretty successful outcome. One of the things that we should be thinking is that, the stress test that we're doing is basically putting a controlled amount of stress that's similar to the mechanism of injury, right? So when we're looking at what our stress tests are, we're looking at basically doing tension stress tests. Tension stress tests are going to be our ligament tests. They might be our nerve tests. So with respect to ligament, if you think about it, our MDIs are putting tension on the capsule. Our unicollateral ligament throwers, we're putting a milking stress test or a moving valgus, which is going to put tension on that ligament. MCL, Lachman's, again, tension, looking at Enfield. The mechanism for all those ligament problems we just talked about is some type of overtension. So, to make it easy, we get a lot of, students in and they're trying to remember the name of the test, and we'll say, hey, don't worry about the name of the test. What is the test you're doing, physically doing to that tissue? Don't worry about the name. Let's actually think it through. This is how it got hurt. Let's put that same stress through it and see if it's positive or negative. Obviously, resisted tests with muscle tendon, they're contractile. Someone should walk out of a room saying, hey, this guy's got a supraspinatus problem. Why? Because he had pain on contracting it or passively stretching it. Compression, torsion, shear tests. Well, labrum, discogenic issues, meniscus, right? When we're looking at compression, rotation in the shoulder, flexion, adduction, internal rotation, Thessaly, where you're standing and torsioning that meniscus. So our stress tests really are the same mechanism as the mechanism of injury. As we'll talk about shortly here, some of the loads we're putting through that tissue to enable it to heal are exactly that, but on a controlled and graded amount. One of the probably best things that was contributed to the profession of PT was by Dr. Syriacs. Cody and I like to pay homage to people that have done a lot of work in our world of PT, and his contribution to what we all do is basically selective tissue tensioning. And basically it goes right in line with teasing out what someone's problem is. And again, just to reiterate, cartilage, you're looking at compression, torsion, stress tests. With ligament, you're basically putting tension on there. With bone, you're going to weight bear, you're going to tap on it. With bursa, these people all have compression problems. They can't lie on that right hip because it compresses it. They get pain when they get a glute med contraction because it compresses it. Muscle tendon is the obvious. Nerve tension, we should walk out of a room, eval room, thinking, okay, the problem that this patient has, radiculopathy, it's a nerve issue. And it's a nerve issue because there was some kind of reflex delay, or there was an upper limb tension or straight leg raise or positive, but we're stress testing each of these tissues to basically confirm whether it is or is not the culprit. I will apologize for this. We're going to spend just a brief amount of time looking at really boring stuff, but very important stuff. I think Patrick over there is almost falling asleep here. We're looking at the stages of healing here, right? So if we look at post-injury, the very first thing that happens is an inflammatory response. And that inflammatory response is usually 2 or 3 days, but up to a week, let's say, where we get platelets that are rushing in, bringing growth factors and creating and stimulating that tissue repair cycle. The bulk of probably what we see in therapy are patients that come in really in the proliferative / reparative phase 2 or 3 weeks later, right? By the time they injure themselves, they're in denial, they try ice and all this stuff at home, they maybe go to the doctor, hopefully go to the physician to get screened. By the time they get on the schedule to come see us in therapy, it's 2 or 3 weeks later. So, the times we're seeing a lot of the patients and or the majority of patients obviously is as early as possible, but the reality is it's probably closer in the proliferative reparative phase, which is probably the most important part of the healing, where you're getting collagen deposition, tissues getting revascularized, growth factors are being secreted, and basically cell proliferation is happening. And we'll talk next month on the biologics. That's a critical component of how the biologics PRP stem cell work, is basically facilitating that cell production, letting the inflammation roll on, and get into that remodeling phase where we can pull out our tools, or we can pull out some of the manual techniques and really work on getting that tissue to realign so it's healthy and parallel and in the anatomical state that it's supposed to be functioning in. Something we tell patients all the time in our students, basically all tissue heals with vascularization, vascularity. So the goal really is to get as much blood flow into certain tissues as we can. And I probably should have put cartilage here at the front, but we're looking at from less to vascularity, less blood flow, to more vascularity, blood flow. Obviously, muscle's got the most. Muscle tissue heals the fastest. If we do too much too early, break out tools, eccentric load too soon, stretch it too soon, you run the risk of calcium deposits or myositis, ossificans developing. So as quickly as we think muscle can heal, we still have to go through kind of a graded process. But all the basically loading that we're going to be doing, loading meaning, and we'll talk about this, modalities, to our exercises, to our manual techniques, to BFR, what have you. Hopefully a lot of that's geared towards getting more blood flow into tissue, which is then going to facilitate cell production and basically get us from this inflammatory proliferative into the remodeling phase. So think about that, and we're using modalities. Hopefully the purpose is, maybe it's swelling and pain reduction, but a lot of what we're doing is basically getting blood flow to tissue. How do we do that? Yes, modality, we're doing that. I think people should probably think about, early on in some of the cases we're working with, a lot of times we'll hear, people given 10 reps or 12 reps of exercises. And then if we stop and think about it, early on, we're trying to get vascularity and tendon tissue endurance. Why aren't we doing 25 or 30 or 40 reps? And as the week 4, week 6, the remodeling phase kicks in, going towards hypertrophy or true strengthening, we probably should be working our way back down towards 8, 10 reps, 12 reps. So the sequencing and why are we giving people repetitions and how much, I think sometimes is a little confusing to therapists and students. But let's think about that, because it's one of the things that we're trying to do early on, get vascularity, later on remodel and strengthen. Obviously with cardio and getting patients doing cardio on the side and to enhance vascularity is what we're looking at. BFR, I'm happy to hear that, right, Starla, we have a BFR lunch and learn coming. We're starting to see a lot of research come through with BFR. The first time I got exposed to it was in 2016 or something like that with the Olympic team in China. And I watched the Aussie physios there. Don't call them PTs, I call them physios. The physios there were doing BFR, and and then all of a sudden you come back and, it's all over the JOSPT journals. And in the last 2 or 3 years, we get doctor's office after doctor's office, asking if we have BFR. So as Kyle and those guys can say, it's not the end all, but it's definitely becoming part of a standard of care. How do we increase vascularity? Our manual therapy is one of the, behind exercise, probably one of the best ways we're doing it. All kinds of great manual techniques, soft tissue work, using tools, Graston, ASTEM, et cetera. Cupping, there's a ton of different good manual techniques that, again, isn't the end all. It's probably one of X parts of the treatments that we should be doing. Another question that we'll talk, or we should probably start thinking about, is when should we stop habitually using ice? I think a lot of times therapists and patients get in the habit of just icing everything for some reason. And ice has its place, but if we just looked at that slide, and we know that inflammation really only lasts from, minute 30 all the way to hour, 72, or the first, 1 to 5 days. And here we are at 6 weeks with a rotator cuff tendinosis or a post-op patient, and we're still icing and stimming. Maybe we should be using heat with modalities, or heat to stimulate that vascularity. Something to think about. It reminds me when we watch, baseball, and you see that pitcher, you see Clayton Kershaw in the dugout at, for him earlier, but 6, 7, 8 innings, and they're sitting there wrapped in ice to control any inflammatory process rising. What the TV doesn't show, and what people don't realize, is Clayton Kershaw and these baseball players, they're probably doing 3 to 4 times the amount of cardio later that night at 11 at night to revascularize that tissue. So keep thinking blood flow, because that's how tissues repair. Again, one of the best ways that we can improve fiber alignment and tissue repair is with deep friction massage, deep friction mobilization. And in a nutshell, you can read through this later, but we're basically trying to get tissue to distort in that reparative remodeling phase, increase the local hyperemia of that tissue, more blood flow, prevent that scar tissue from forming, and hopefully stimulate collagen fibers that are parallel or should be going in along the lines of stress. Concept called Wolff's Law, going back again to early PT school days. Basically, the gradual application of stress is a stimulus for further tissue proliferation and differentiation of chondrocytes and fibroblasts. So putting stress, or applying stress through manual work or through exercise, is going to enhance the structural tissue integrity as additional fibers are laid down in response to that stress. So tissue adapts to cyclical loading under which the stress is placed. I can't see because I got a screen here. This other guy, Davis, I don't know who Davis is, or I don't even know how you can get a law. Maybe Starlin knows. How do you get a law put in under your name? But Davis's law is basically similar, and it makes sense. This guy's right. Soft tissue will heal according to the manner in which they are mechanically stressed. So the key is basically putting stress through tissue. And the example that we tell patients, with bone, and you look at astronauts that go up into outer space, they come back and they shoot x-rays of these guys and girls' tibia, and it's basically translucent. There was no, up until recently, bone, no metabolic calcium bone being laid down, because there was no physical stress. And so whether it's putting tension on an ulnar collateral ligament, putting eccentric load through a supraspinatus tendon, or putting some weight progressively, toe touch all the way to full weight through bone, that's how tissue heals. And so a lot of what we're doing really is applying Wolff's Law into tissue repair mechanisms. Now let's look specifically at a few tissues. Cartilage basically has a very limited healing capacity, avascular. There's a low turnover rate. It really depends on synovial fluid. And so cartilage basically, as it's replaced with fiber cartilage after some kind of injury, that new cartilage or that new lining lacks the shock absorption. So once we have some cartilage deficits in place, it's hard. There's no reparative ability, or there's a lack of reparative ability. It lacks the stiffness and permeability, and doesn't have the same compressive properties. So it basically, the key with cartilage issues, whether you're looking at hip labrum issues, knee Cartilage deficits, annular tears is basically, how much are we going to load that? How much are we going to weight bear? Are we going to avoid torsion through that tissue? Moderate loading is what's going to be aiding that repair. Excessive loading, that's why runners typically don't do well with moderate osteoarthritis. It becomes detrimental to the cartilage. On the flip side, insufficient loading, not moving, too much immobilization early on, especially after surgery, is going to have some adverse effects and probably lead to a decreased, cell production. So the key for cartilage labrum issues is, and I wouldn't put shoulder labrum, I'd put cartilage and hip labrum into this category, is basically weight bearing and moderate loading, high repetition, low load. And the best way we describe this to patients is we use describe it like a pumping effect. Again, the nutrition is basically coming through synovial fluid. The tissue is avascular, and we're looking for that imbibing of nutrients in and out of the cartilage from a repetitive compression, decompressive loading and unloading. And we'll use the analogy of a wet soapy sponge. I put that sponge on the table and I put my hand and squash that sponge. Well, that pressure is going to get soap suds to come out of the sponge. I take my hand off, and those soap sponge are going to kind of seep back in. So you get this repetitive inflow, outflow of nutrients. And the way to do that is, as you guys, as we all know, it's low impact. It's being in the water. It's stationary bike, getting proximal muscles and distal stability, et cetera, all in place. But from a tissue healing, cartilage healing, it's basically trying to maximize synovialization in the fluid. We'll do actually a lot of unloading in our clinic, as much as we do plyometrics and some of the heavy duty stuff early on. We'll get people, less than body weight to try and then bring them up to full body weight to plus, what have you, full body weight with resisted bars and plyometric loading. So it just depends on what stage they're at, again, what the irritability level is and what the goal of the exercise is. Quick summary: cartilage, very limited ability to regenerate. We just talked about the compressive and pumping effects. That's what stimulates the healing, the synovialization. Yes, as you guys know, catching, locking, crepitus, lack of stability are all common subjective complaints. And what we really want to do, especially in the shoulder, is we want to avoid excessive joint compression or excessive torsion in that earlier phase. And then if it's appropriate, wean in those stresses or those loads later. I think we have a lot of, I think, McKenzie trained people in spine and sport, and everybody thinks McKenzie is an extension-based program, which early on it is, but towards the latter part, Robin McKenzie pushed for full flexion and torsion, flexion rotation. And the reason is you want to get that full force and stimulate some of those annular fibers that resist those torsional forces. So adding back in compression torsion later phase is important if it's appropriate. And again, earlier motion is better. When we're looking at ligament tissue, switching gears, again, not a lot of vascularity, poor healing, very similar microscopically to tendon tissue. And the reason that's important is the fibers are really, and hopefully should be, aligned in a more parallel fashion. And a lot of what we're doing for tendinosis problems and ligament issues in that remodeling phase is deep friction mobilization, again, to try and break up adhesions and then load it with exercise that's going to then tension that ligament or tendon so those fibers become parallel. So getting tendon and ligament tissues to line up in a parallel fashion should be the goal. Again, excuse me. Ligament issues, maybe it's macro trauma. It's a guy, coming down inadvertently on someone's foot. Commonly, and in our office, we see a lot of overhead throwers and tennis players, and it's sometimes a micro trauma where you're just going through that repetitive motion, putting tension through that tissue. Again, and same concept with inflammatory, reparative phase, et cetera. But basically, early on protection phase to stimulate the matrix formation, allow those cells to bind down. And we'll talk about this in the PRP lunch and learn, and get that orientation of collagen starting to line up, but not putting too much motion through there or disrupting the healing early phase, healing reparative phase. Moving forward into maturation and remodeling, that's where we want that cross-linking of the collagen fibers. that's when we'll pull out our tools, our Grasson, ASIM, what have you, deep friction mobilizations. That's when we'll start loading up and putting valgus torque through it. That's when we're doing our PNF and really trying to put, a lot of different angles of force through there, so the neuromuscular system stabilizes. And yes, so those tendons / ligaments in this case respond to that stress by being able to withstand a bigger force. We're going to scoop through this one. When we're looking at restoring neuromuscular control, we want to restore that mechanical ability. We do a lot of perturbation, a lot of reversal, PNF type stuff, putting in destabilizing forces, which help develop strategies for when real forces are being loaded through there during everyday function. Progress from low force on ligament injuries to high force, from slow speed to fast speed, from controlled to less controlled scenarios, and from obviously, weaning in non-competitive exercises or non-competitive game situations towards full competitive or modified, practice situations. It kind of goes along with the concept of we don't want to see patients doing the same exercises at week 4 or 5 as they're doing at week 10 or 11. And we want to see a little bit of progression, and we want to see a little difference in speed and or loading if it's appropriate. And so, we use phases a lot in our Thousand Oaks office, and we try and get people, if it's appropriate, from phase 1 all the way to phase 4 or 5, return to play. And in order to do that, you got to progressively load tissue at different levels, different speeds, different resistances. Low load, prolonged stress on a ligament tissue. Good examples are adhesive capsulitis patients. There's a concept called TERT, T-E-R-T, total end range time. This is a George Davies concept, I believe, where you're putting, mechanical stress through that tissue. You're basically heating it with modalities, with cardio, what have you, for 20 minutes. You're going to impart your manual therapy / exercise for 20 minutes, and we're going to put them back on an extended quadrant position, on a tension position, with or without ice again at the end. And over time, you're looking at tissue creep or tissue elongation with that load. Quick summary: ligaments have poor vascularity, not great healing capacity. It's one of the things we see with why our PRP patients that we've seen over the last 10 years do really well. 50% or less with onocollateral ligament tears seem to do a little bit better than they were doing prior to integration of PRP. We'll talk about that. The importance of manual therapy and in creating fiber alignment, and then controlled stress in the line of fiber is really the key. We switch gears to muscle tendon healing. Parallel fibers. Tendon has the highest tensile strength of any of these tissues. And basically we're looking at motion and stress in the sense of increasing the collagen production or increasing the cell production. Again, are we looking at a tendonitis or a tendinosis? I think we treat those two different scenarios differently. Again, if patients don't get to us till week 4, week 8, and we're still icing and thinking it's a tendonitis, and they're taking anti-inflammatories, and they're like, hey, it doesn't work, nothing's changing. Let's flip our mindset where, this is not a new concept. We're looking at a degraded tendon, or a scenario where those tendon fibers are all they're not parallel, they're cross-linked and matrixed. And so we got to almost stimulate inflammation and stimulate a little tissue irritability with friction mobilization. It's probably one of the reasons globally why eccentrics works. But you're basically stimulating inflammation to jumpstart the tissue repair cycle, which is what PRP and some of the biologics is doing. So think about the anti-inflammatory approach when we're looking at some of these tendinitis, and or do they need something more thermal, more remodeling, more eccentrics? Again, reparative phase on tendinitis or tendon tears, maturation phase, where we're trying to get the cross-linking going, and the remodeling phase, we're actually trying to break it down and stimulate it up. Decreased vascularity. We're trying to enhance growth factors and circulation. And with tendon, we should start thinking the load that tendon needs is basically contraction / eccentrics, and integrating our manual therapy. If any of you have taken some coursework with David Butler, he's probably credited most with being an authority on neural tension and neural dynamics. And he's the one that brought that concept to us here and taught us as a profession, the value of potentially neural dynamic flossing. And basically, the purpose of that is you're increasing axoplasmic flow and you're desensitizing the nerve. So you start doing nerve tension, flossing in sciatic nerve or ulnar nerve. Patients will ask, what does this do? We'll tell them, hey, this is increasing the circulation, helping the conductivity and increasing the axoplasmic flow. So it sounds smart to some of these patients, which is true. You're trying to basically stimulate the nerve's version of vascularity, axoplasm. And again, not sets of 10. If you guys ever meet David Butler, he looks like Phil Collins. If you guys know who Phil Collins is, Aussie, real eclectic. And, he has people doing, 25, 30 oscillations, 15, 20 times a day. So in the pain-free range. I like this chart. I'll let you guys look through this later. But the crux of it is here are these different tissues that we're looking at that we're treating. Here's, is there blood flow? Yes or no, or is it diminished? What force are we looking at to impart with our exercises and home programs? Tension, yes, in the line of stress. For ligaments, cartilage, very cyclical compression, decompression, and maybe a little bit of shear rotary force on some of our labrum, discogenic issues. For bone, obviously controlled weight bearing. Osteoporosis is an obvious resisted weight bearing exercise, how you treat, bone remodeling in osteoporotic patients. Contractile loading for muscle, getting towards eccentrics. And same thing for tendon, progressing from early on isometric to concentric to eccentric to plyometrics or ballistic, with or without BFR on some of these. Tissue loading, super important. Again, involves range of motion, submax going towards maximum loading, dynamic stability with PNF and some of our neuromuscular techniques. Basically, the gradual application of stress is a stimulus for further tissue proliferation and differentiation of chondrocytes and fibroblasts, i.e. cells. We want better tissue integrity. Early on, less is more when it comes to loading. As time goes on, more might be more. How much is optimal? Again, early is better. We want a functional approach. We're looking for a better fiber alignment. The nature, direction, magnitude, intensity, and duration of applied load to effective tissue that maximizes tissue adaptation and restores function. Think of this, your exercise progressions and your manual interventions, hopefully are working at the cellular level to improve it. We're basically stimulating cell production, breaking adhesions, and helping facilitate cell proliferation. How much loading is great for tendon and ligament, and even for post-ops, all the way to the biologics. It's not very well defined in the literature, especially for tendon and ligament. But we've all seen enough ulnar collateral ligament repairs or rotator cuff repairs, and every patient's a little variable, so we adapt that to the specific patient. But we have an idea of that time frame that we'll talk about next week, in our next month in the biologics. Characteristics of optimal loading, functional ranges, putting a blend of compressive, tensile, shear loading. Most everyday activities, most sports, throwing, running, what have you, it's not uniplanar, it's multiple angular, it's multiple different forces going through. So we try and stimulate that in the rehab process. It's variable in magnitude, direction, duration, and intensity. Maybe that could be the Vernal law, the Wolff's law and the Stevens law. We should have a Joe Vernal law. And I think I've seen a lot of stuff from Joe come out about high intensity interval training for low back pain and making it variable. And you're basically your back and neuromuscular system start adapting to that. Your cardio system adapts to that. So we'll start pushing a Vernal law with variability and high intensity. Include neural overload and make it functional, of course. The guiding principles, basically, in what we do, we're balancing load and rest. How much load is needed versus how much rest is needed, and that's a tricky balance to teeter on, especially when patients are go, and you want them to rest, or they're not doing their home program, and you want them to go. And so pushing towards the load concept, but making sure we're resting at the appropriate times and not doing things too early is always the teeter balance that us clinicians are facing. How do we load? And loading this is what therapists have been doing for ever since we've been in existence. We're always loading tissue, and the concept of load management in the world of sports has become a big punch term in the last, Kyle will tell you, 5-6 years. And LeBron James is, he's sitting out half the season because they don't want to load him too much, or pitch counts and all this, all very good stuff. But loading is something that therapists should have been doing and are doing basically as our profession. We're either unloading something, with bracing or with crutches. We're loading up and increasing vascularity. If we think ultrasound and extracorporeal shockwave and laser and all the bells and whistles modalities that we have, if they work, which there's research shows that it does, at the appropriate time, we're integrating that. Like I said, the best way we're loading tissue is basically through our manual work in our hands. We're doing some neuromuscular re-ed for almost all our patients, PNF and single leg stance, proprioceptive perturbation type stuff. And then, of course, we're doing TheraX, their activities and strengthening. And so, in our office, we're doing some kind of combination of modalities. We're doing manual therapy for almost everybody. We're doing an NMR technique to reinforce the manual stuff. And of course, we're doing some kind of TheraX, their activity to reinforce the manual work and the neuromuscular re-ed that we did. And separate topic, we're charging for all that. We are, and that's not Joe and Brett didn't ask me to punch that, but we patients are here for an hour. So, we're billing all those out. We're giving the patients what they need. And we want all 3 or 4 of these to be included in our treatment because the variability is what is going to help some of these impairments, and variability is going to help one another get that tissue to facilitate healing. We will talk next month about orthobiologics. What is it? Who are the candidates? And give a brief overview of how the docs are going about doing PRP injections and stem cell and BMAC. And I think if you guys remember, a lot of the stuff in the world of sports with respects to some of the orthopedic treatments is how it gets notarized. So I think Kobe was one of the earlier athletes that went out to Germany to get some injections, and he could do it there because the PRP / stuff they were using with biologics was, outside of his body or outside of the patient's body for, longer, 3 hours. But in the States with the FDA, they can only have the blood outside of the person's body for a limited time, et cetera. So the world of sports has kind of made a lot of the biologics and the stem cells become more notariable. And now, as hopefully research comes out, insurances will start paying for it. Hopefully we'll be able to jump the gun on our competition, and we have a bunch of protocols that we've used, and we started seeing PRP back in 2008, 2009. We've written some textbook chapters and probably have 200, 300, 400 cases that we've looked at, and kind of made a bunch of errors like we all do because we're practicing PT, and those errors shrunk down, and now we kind of have a better handle on why we do what, or why we do what intervention at what time following PRP. And it's based on all the things we just talked about as a summary: tissue repair cycle, the 4 stages of healing, when to integrate what, and better manage those platelet-rich plasma orthobiologic interventions. So hopefully we can also give you guys some protocols that we've developed for proximal hamstring, for flexor carpi ulnaris, for we call it a weight-bearing tendon. It's really not a weight-bearing tendon. It's a tendon that's basically supporting a weight-bearing joint. So Achilles and patellar tendon, we go a little slower with those post orthobiologics than we do maybe with supraspinatus or extensor brevis, et cetera. And again, see if we can help you guys to develop a niche market and maybe market that to some of the docs in your areas that are doing PRP, and show them, hey, we have some protocols here. What do you think? And help you guys establish some strategies to establish relationships with those referring physicians. Takeaways, the key is understanding what tissue that we're treating and be able to stress that tissue. have an understanding how that tissue heals. Is it avascular? Is a little bit of vascularity to it? What are the tools I have in my toolbox to get that vascularization going and maximize it? When do I integrate the tools? Not tools, the tools, the Grafton stuff, the tape, the manual deep friction mobilizations, the eccentrics, and putting that in the right phase, in the right stage of healing is the only way we can set ourselves up to win. And again, a new frontier coming up that's been here for 10 or 12 years in the States with biologics and stem cells, a new frontier that we'll talk about. So that is all I have. If there's any questions, we can go through those now, or we can talk later next week. Again, we have a bunch of good, materials that we've developed with and lectures that we've done. So if you guys want more, everybody's got protocols, but I think one of the things that Kyle and Starla were looking at doing, we're kind of putting a database on there. So all of us clinicians can tap on and say, okay, here's 10 or 20 different protocols for, a cartilage implantation, procedure, or here's, what we do on Tommy John. So I think the key is just collaborating and really having an understanding on tissue repair, and then integrating some of those protocols and concepts into your particular specific patients, because every patient is a little bit different. So Starla, what do you think?
Yeah, awesome. Thank you so much, Eric. We do have like 4 minutes left. So if there are any questions, you can unmute and then ask Eric now, or you can throw it in the chat.
Or Kyle can answer them all too. He said he was good at it.
We do have one in the chat. David Ruella says, microphone isn't working. Sorry. What's the best TENS e-stim setting for tissue repair?
Oh, Ruella's, he's probably sitting right over there. I don't know that TENS stimulates tissue repair. There is a Kevin Wilkes protocol where it's a high frequency Russian setting that we'll use for tendinosis. And we do that a lot even for the post-ops, where we're use supraspinatus or extensor brevis as an example. Extensor brevis, you're almost creating a semi-noxious input from the use of Russian electric stim, and actually physically getting that contraction to happen. So you put that on 2 pads, 2 leads. It's a higher frequency, high for sure, almost noxious. Where we don't want it we want it uncomfortable, but not within reason. We are physically going to see that muscle contract, and we'll do that typically mid part of the treatment or at the end. And again, we talked about sequencing. If the concept is to try and get blood flow into that tissue and get that extensor brevis to contract, then maybe we sequence it where we're doing eccentrics or some kind of PNF or some kind of wrist extensor loading with exercise after that, to get that tissue to contract and then start lining up parallel and break it up from getting out of this matrix phase. So Ruella should know better that TENS isn't necessarily the go-to for that, but I can find out and get back to him on that one.
Hey, Eric.
Yeah.
I was wondering if you're familiar with the the patellar tendinopathy protocols developed by Jill Cook over in Australia, kind of like the daily load test and sort of the daily loading as an approach to patellar tendinopathy. And I think kind of along with the argument that a lot of the tendinopathy research that supported largely Achilles issues and particularly eccentric loading has been kind of extrapolated to all tendinopathies, but isn't always necessarily, since not all the tendons are exactly like the Achilles, isn't always necessarily immediately appropriate.
Yeah, that one, not exactly familiar with the specifics on that, but with patellar tendon, again, similar in concept with it supporting a weight-bearing joint. And when you look at ground force going through an Achilles, through the ankle, that the Achilles has to generate torque or decelerate. And then you look at the ground force that happens with decelerating stairs and what that patellar tendon has to go through. The eccentric loading for Achilles research was, talking 5 times a day, 3 sets of 35 reps with resistance single. There is good research on that. I think in the patellar tendon, if I just look and think of what we've seen clinically here, I think it's the denser component and the fibers and where it's torn / fibrotic. It's a much denser, thicker tendon than Achilles. And so some of our treatments may not be targeting that. And And the ones that have gone on to do well, or when they go in and they do basically almost, they puncture the proximal tibia and get that intermedullary bone microfracture going, and almost stimulates a blood flow, almost like a microfracture technique, into that tendon. I don't know that you can extrapolate and say, hey, we're gonna need to do, patellar tendon loading, just like we would do Achilles. That's the approach we have taken. And again, for patellar tendon, because it's so dense, and off the record in California, hopefully Rick will get this punched through for us. I think that's the reason why dry needling probably works really well for that, to be honest with you. Run a microcurrent through there. The microfilaments are going through and into that part of the tendon. Now you're running microcurrent and blood flow through there. Follow that up with eccentric loads. So I don't know if that answered your question, but
no, yeah, I was just curious on your opinion on it, and I could send you some stuff on it because I did a good amount of research on it a while back, and it's pretty interesting. But yeah, it's like a whole protocol starting with isometric loading.
Right.
You do a daily load test, and based on the daily load test, you know whether or not it's appropriate to progress or not.
Yeah, no, that makes sense. That's something exactly we should put in Starla and Kyle into that toolbox side if we ever get that up and going. And that's kind of what we're going to talk about. I know we're out of time next week or next month on kind of a criteria-based approach following PRP. So it sounds like that's a criteria-based approach following, your interventions for patellar tendinopathy.
Cool. Thanks.
Yeah.
Awesome. Thanks, guys. So we are out of time now. Like usual, I have this recorded and I'll post it to the YouTube account. I know a couple of you missed the first few minutes of the lecture, so I'll have that posted by the end of the day. Eric, just a couple things to follow up on. Eric was alluding to the fact that we're going to have a database of protocols and things like that. That's going to be through iSolved University for those who have been on that. If you haven't been on it, you will be soon for your compliance training. So you'll get introduced to it and you'll see there's a whole database of resources for you guys on there. And then finally, as we had stated before, this is kind of like the precursor to next month's Lunch and Learn. So if you like this, definitely come for next time. It's going to be a little bit less academic, Eric, right? Maybe a little bit more exciting next time around. So we're excited for that. All right. Yep. Thank you so much, Eric. This was awesome. And we will see you all next month.
All right, guys. Have a good day.
See ya.